End-of-life care. End-of-life experiences are very different in today's world compared to 100 years ago, where death often occurred in the home with family givers and all family was usually near. All members of the family were exposed to death and each culture developed grieving processes. Death is associated with old age due to advances in technology and medical care, but it's also associated with chronic or debilitating diseases. It reflects culture that emphasizes individualism and self-reliance. Death and dying is subject to regulations intended to preserve autonomy and provide necessary services and protection, as death not only encompasses the physical realm, but also the psychosocial, ethical, legal, and administrative issues. Older adults often have to navigate regulations alone, which can be very difficult, and this increases stress and frustration, not only for the dying, but for the family. Effective end-of-life care is often given too late to be of maximal benefit. Groups working together to improve end-of-life care include organizations such as the National Hospice and Palliative Care Organization, American Geriatric Association, Institute of Medicine, American Association of Colleges of Nursing, and Robert Wood Johnson Foundation. Many people in Western cultures, mainly America, have little experience with death or dying until middle or late adulthood. In the past, healthcare professionals often made decisions about end-of-life care, and there was minimal input from the client or family. But it's now understood that healthcare consumers have a right to guide their care according to their personal beliefs and preferences. The healthcare professionals now help clients make informed decisions regarding end-of-life care. End-of-life care is now approached more with a holistic approach rather than a purely medical focus. Some clients want to pursue every possible treatment while others choose a comfortable death with loved ones close by. Many people want to participate in end-of-life planning rather than leaving it up to the healthcare providers. And there's many resources now available to these people. Still, many people find it difficult to discuss death. Personal values, cultural and spiritual beliefs, and life experiences all affect those choices. Many older people say that they don't fear death as much as they fear how they're going to die. Ideally, discussions regarding end-of-life care and death planning are going to occur before a health crisis arises. Advanced directives are going to allow for specific end-of-life decisions. Once initiated, they'll remain in effect until changed. They specify the type and amount of intervention that's desired by an individual. They're very personal, and no single right plan is out there. It should be the client's choice. Individuals should make informed decisions regarding end-of-life care, and it's important to provide copies of advance directives well ahead of time to those that are going to need them, and they should also be visibly posted in the home. Primary care providers and the person holding the durable power of attorney are two of those that definitely need copies. Now, before deciding on the content of advance directives, the client needs to know how much time will treatment add to life expectancy. What is the quality of life without this treatment? How much pain, disability, or risk is involved with treatment? What is the cost of treatment, and is it covered by insurance? Is there a need for and availability of caregivers? Is there availability, benefits, and risks of other treatment options? They need to review with their family and/or request information from additional healthcare providers. Caregiver attitudes toward the end of life, they might view death as a personal or professional failure as healthcare professionals. And they're often focused on treating or preventing illness or curing diseases. Healthcare workers need to be aware of their own attitudes. They must collaborate to provide holistic care to the dying person. Excuse me, and they need to overcome frustrations or ineffectiveness to help that dying person and the family experience what we call a good death. This involves addressing the needs of the family, friends, and significant others as they face grief, loss, and bereavement. Caregivers need to know when to shift from aggressive medical interventions to cure or extend life to palliative or hospice care. The goal is to help the client experience a good death, characterized by comfort, peace, dignity, and caring. Beliefs, attitudes, and values about the end of life care are going to vary widely. They're influenced by age, gender, religious background, and life experiences. Ethical dilemmas are more likely to occur if value systems of client and caregiver differ significantly. If the nurse understands the value systems of others, it can help in providing quality end-of-life care. Studies show that most people want to be treated with respect and dignity, to die peacefully and quietly, and to die with loved ones nearby. Human needs at the end of life will mirror human needs throughout their life. Maslow's hierarchy of needs has been adapted to summarize the needs of dying in your textbook. Excuse me. 90% of people surveyed in a Gallup poll indicated a wish to die at home. Fewer than one-fourth of deaths actually do occur at home. Approximately half will occur in hospitals. But unfortunately, hospitals are focused on curative and restorative care, and they may not be ideally suited for end-of-life care. 1/4 of people will die in extended care facilities. The death experience here might be more similar to death at home, but staff may not be able to fully focus on the needs of the dying. Comfort care is defined as a client care plan that's focused on symptom control, pain relief, and quality of life. It's typically administered to clients that have already been hospitalized several times, with further medical treatment unlikely to change matters. Comfort care takes the form of hospice care or palliative care. The National Institute on Aging considers comfort care an essential part of medical care at the end of life. According to the Institute, people who are dying or suffering from a serious illness need care in 4 areas. This includes physical comfort, mental and emotional needs, spiritual issues, and physical tasks. Client comfort can be attributed to a variety of problems such as pain, breathing problems, skin irritation, digestive problems, temperature sensitivity, and fatigue. Hospice care provides end-of-life care. Care philosophy of hospice will focus on humane, dignified, and compassionate care of not only the dying, but also the loved ones. Hospice can be delivered in the community, such as the client's home, excuse me, or in institutional settings, such as a hospice house. A large portion of the dying clients, unfortunately, don't enroll in hospice until about 2 weeks prior to their death. So, as a result, they may not receive the full benefit of this service. The focus of hospice care is quality over quantity. We want the quality of life to be the focus, not keeping the client alive for a longer period of time. Hospice services not only care for the dying client, but also provide comfort to the client's families. The services include the healthcare provider and the nurse. The nurse will visit the home 1 to 2 times per week to assess the client. That frequency can change depending on the client's status. And if they're at home, education of the client's family and the significant others in the client's care and medication administration is very important. If they're at home, the family is instructed to notify the nurse of any changes in the client. The nurse may spend hours with the client or family when the client is actively dying. After death, the nurse will facilitate care and removal of the body while providing for the family needs to spend time with the body for comfort, to answer questions, etc. These nurses often attend funeral or memorial services. A CNA is part of the healthcare team and provides personal care 1 to 3 or more times a week. Volunteers will read to the client, write letters, talk, play music, etc. The social worker is going to help determine the need for durable medical equipment such as oxygen, a hospital bed or commode or wheelchair that's required to improve the client's comfort or care. A chaplain is another part of the team that provides for spiritual needs of the client and the client's loved ones. And it does not have to be of the client's religious background. The client's specific religious leaders are always part of the team. Now, Medicare is going to cover hospice costs for equipment, care, and medications. Palliative care focuses on improving the quality of life for clients that face life-threatening illnesses by reducing their pain and other distressing symptoms. It neither hastens nor postpones death. Interventions are going to be designed to optimize the client's ability to live as active and complete a life as possible until death comes. It does not mean stopping all treatment. However, usually most will decline procedures such as CPR or ventilators or tube feedings. So palliative care focuses on treatment that allows the dying person to have the highest quality of life for the time remaining. Collaborative assessments and interventions for end-of-life care require a coordinated effort of all caregivers. They must work together for the good of the dying person. Problem solving requires mutual respect and prompt, effective communication among all team members. They must recognize the toll that caregivers as well as the dying person uh, that's taken on all of them. Emotional support has to be provided not only to the dying, the family of the dying, but also those caregivers. Communication is always challenging, but at the end of life, there's unique demands and emotional reactions that can make communication even more challenging. Nurses must understand the importance of therapeutic communication, spend time with the dying person, but this is a challenge for nurses that have multiple patients. Nurses need to show respect for the dying person and establish that trust relationship. They need to demonstrate willingness to listen to that dying person and the dying person's family. They need to answer questions honestly and directly, and if possible, involve the client in determining the plan of care. The nurses use reflective and open-ended statements and provide adequate privacy. So one of the most important things that caregivers can do for a dying person is to the correct answer is D, spend more time with them. Cultural perspectives are going to influence the way one thinks, lives, and interacts. They influence views about death and dying, and nurses need to assess each individual's preferences about communication regarding death, the decision-making process, the amount and type of intervention that's going to be accepted, and the significance of pain and suffering. In communication about death, preferences are often culture specific. The Western cultural perspective tends to focus on the right to know the diagnosis and the prognosis, while other cultures will suggest that discussing death is going to diminish hope and lead to bad outcomes. Cultural consideration of a few religious practices are provided in the textbook. Use neutral and open statements to clarify client beliefs and preferences. The client may prefer information personally, but they may also prefer information be given to a loved one instead. And use a translator if necessary when there is a language barrier. With the decision-making process, the dominant Western perspective focuses on the right of the individual to make decisions regarding their own care. But other cultures such as African Americans, Native Americans, Asians, Pacific Islanders, and Hispanic, they're more likely to view those decisions as family issues to be decided by the group, and they are less likely to have advance directives. Many cultures may focus more on living and prolonging life, preferring aggressive interventions at the end of life, and placing greater responsibility and expectations on family, church, or social networks in the provision of end-of-life care. Clients might want freedom from pain, while some cultures view pain as a test of faith or preparation for the afterlife, and pain has to be endured. Nurses can help clients cope with depression, anxiety, and fear by listening to their concerns and helping them find constructive ways of dealing with concerns. Encourage creative and pleasurable activities, physical activity, relaxation classes, accepting anger as being a normal part of the process. Psychological evaluation might be required. And understand that professional help with medications or counselors might be necessary. Religious and spiritual beliefs also play an important part in the lives of many older adults and are potentially more important as they approach the end of life. It helps the clients make sense of their lives and deal with those uncertainties of death. Nurses are often in a position of needing to provide spiritual care to clients, especially during the end-of-life care. This doesn't mean that you have to believe the way the client does. It just means you need to support their beliefs. And if they need you to hold their hands or say a prayer, then that's what we need to do as nurses in providing spiritual care. Different considerations are determining whether there's any specific religious beliefs or practices that are important to the client or his or her family, such as last rites for the Catholic denomination. We need to assess whether the client has a preferred spiritual counselor and offer choices when available. Determine whether the person wishes any spiritual counselor to be notified. Demonstrate respect for the client's religious and spiritual views, and never impose your own beliefs on the client. Be present, be available, and listen. Keep the client's relevant religious symbols readily available and treat them with respect. Avoid moving beyond your role and level of expertise unless you have specific ministerial or pastoral training in death and dying. Changes that we can see as a client approaches death are going to be fatigue, dyspnea, gastrointestinal changes such as dry mouth, anorexia, nausea and vomiting, constipation, anxiety, and delirium. The goal of care is going to be to alleviate suffering and provide the highest level of comfort possible. Pain may be present, but it's not always present at the end of life. Often, the most significant concern of the dying person or his or her significant others is how much pain there is. Pain can interfere with the dying person's ability to maintain control, cope, and complete those end-of-life tasks. It does increase the likelihood of fatigue, depression, and loss of appetite, and it's one of the most important priorities in care. The pain assessment has to be thorough, as early in care as possible and as often as needed. Clients may underreport, so regular evaluation is so key. The goal of pain management is to reduce pain to an acceptable level as defined by the dying person, while maintaining the level of alertness that allows them to remain aware of daily activities and to interact with their family and loved ones. Evidence-based principles for end-of-life pain management include not giving up trying to find effective pain management techniques, knowing that the likelihood of drug interactions increases with new drugs or dosages, frequently evaluating the effectiveness of pain management, considering a variety of routes of administration, paying attention to the timing, and giving it before it becomes severe, never stopping a medication abruptly if it's been taken for an extended period, and use non-pharmacological approaches to complement those pain medications. Consider referral to a pain specialist. Fatigue and sleepiness may also be seen towards the end of life. It can be caused by the underlying disease process, stress, anxiety, or medications. It can interfere with the dying person's ability to carry out necessary end-of-life tasks, including communication with loved ones. Because of metabolic changes, the client may begin to sleep more and may be difficult to awaken as the end of life nears. Intervention that may help reduce fatigue includes stimulants, pacing physical activity, and frequent rest periods. Cardiovascular changes we see may be diminished peripheral circulation. It's likely to worsen as death nears, resulting in dry, pale, mottling, or cyanotic extremities. Peripheral pulses will be weak. Blood pressure typically will be decreased by 20 or more points from the normal range, and it may be difficult to auscultate. Body temperature may elevate significantly as death nears, and room temperature and ventilation should be adjusted to promote comfort while avoiding chilling drafts, maybe using some bed socks or shoulder wraps or warmed blankets. Respiratory changes that might be seen are dyspnea, Cheyne-Stokes respirations. Other difficulties may include increased secretions. Treatment needs to focus on symptom management and elimination of the underlying causes. Severe breathing difficulty may require morphine if the dying person does not want aggressive treatments. Gastrointestinal changes are going to include that loss of appetite, also known as anorexia. We're going to have muscle wasting, which is known as cachexia. The dry mouth or xerostomia and ulcerations in the mouth may be apparent. An inability to take food or fluid by mouth. Artificial feeding or hydration might be an option, but it might be more of a burden than a benefit. All it's going to do at this point is prolong life. It's not going to change the outcome. Constipation is very common. Nausea and vomiting are not signs of impending death, but are rather signs of underlying conditions. Urinary changes seen. Oliguria is common. Urinary incontinence is also common. So the use of absorbent pads or an indwelling catheter can reduce disturbance of the client as they're going through this transitional period. Integumentary changes are expected because of malnourishment and decreased circulation. So interventions to prevent skin tears or pressure injuries include proper cleansing, careful handling of the skin, frequent turning and positioning, measures to reduce pressure. Soft, non-constricting, non-irritating clothing can help promote comfort and minimize risk for skin dryness and rashes. Cotton clothing is the best option because it's comfortable. It breathes and allows perspiration to escape and keep the skin dry. As the client nears death, vision diminishes and the visual field will narrow. Hearing remains acute until death, even if the dying person does not respond. So we always encourage the client's family to continue to talk, to let them know or talk to the client because they will hear. Calm, supportive, loving messages need to be delivered even when the person is unresponsive. Negative or disturbing conversations should be avoided to reduce stress and agitation. We're also going to see changes in cognition. Delirium is very common near death. Causes of delirium are going to include hypotension, oxygen deprivation that results from apnea or hypoventilation, fever, neurologic changes, metabolic abnormalities such as hyperglycemia and uremia, dehydration, and other physiologic or emotional disturbances. Calm, reassuring support can help manage those symptoms. Discontinuation of some medications may also be helpful. Family members and significant others often wish to be present at the time of death. Some families can spend only limited time with their dying loved one, and they wish to be called only when there's a significant change in the client's status. Others would rather be notified only after a death has occurred. Family responses are based on their coping ability, their access to resources, work situations, health of other family members, and the relation to the dying person. So we cannot be judgmental. Nurses have to recognize that the family response is going to be varied and, again, not be judgmental. Discussion of the family's wishes early on so appropriate notifications can be made is very important. We need to document and communicate family instructions, including who needs to be contacted and how to contact them. Offer and allow family to participate in the dying person's care and educate on care directions as necessary. Allow expressions of emotion. Provide frequent status updates, reassuring that the client is comfortable and be sensitive to family needs. Recognize imminent death. Death can be slow or it can be very quick. These clients will have, once again, increased sleepiness, decreased responsiveness, confusion in a person that has been oriented, hallucinations about people, sometimes about deceased family members, increased withdrawal from visitors or other social interaction, a loss of interest in food and fluids, a loss of bowel and bladder control, altered breathing patterns, involuntary muscle movements. Signs of death will include absence of a heartbeat and spontaneous respirations, open eyes with no blink, non-reactive pupils, a flaccid jaw and slightly open mouth, a lack of response to touch, speech, or painful stimuli. Remember that the legal pronouncement is usually made by the physician. After death, if family members are present, they should be allowed to sit at the bedside and say farewells or grieve as long as they need. Usually what I would do is, if you would like to step out for a few minutes, we will get your loved one cleaned up and remove some of these wires or tubings, and then we'll allow you to come back in and you can stay for as long as you need to. It is appropriate for the nurse to discreetly remove oxygen, IV lines, or other medical devices that are visible if the family doesn't want to leave. Cultural practices regarding grieving and preparation of the body need to be respected and accommodated whenever possible. The nurse needs to notify the physician and the mortuary, noting the time of death if it's witnessed, or approximately if it's not witnessed. Gather and list the belongings if the client passed away in an institution and document the disbursement of them. Provide postmortem care consistent with cultural and spiritual preferences with agency policies. And these can include things like bathing the body, changing linens or clothing, inserting dentures, and closing the eyes and the mouth. And then the nurse should assist mortuary personnel as needed in removal of the body when that time comes. Most older people have given some thought to their final resting place, and many have made specific plans, issued specific directions regarding their wishes, and in some cases even paid for their funerals. It's highly influenced by culture and religion. It is appropriate for nurses to attend services if they desire. There's usually complex psychosocial and physical responses to death. There's no good or right way to feel following a death. Signs of grief usually decrease over time. However, most people require at least a year to work through that loss. However, that loss never completely goes away. Nurses can help by encouraging that grieving person to take time to cry and express their feelings, to review and reminisce about the good times. By listening to the grieving person talk and recommend bereavement support groups when appropriate, and refer the people to a grief counselor in cases of severe or protracted grief. The Kubler-Ross stages of grief say that there's no set time for grief to last, and many people may not follow the stages in order, or they might move in and out of the stages. These include denial, anger, bargaining, depression, and acceptance. When the client does not want aggressive medical treatment, the most common method used to manage shortness of breath is the correct answer is administration of morphine.